I've invited Dr. Carrie Rosenkranz to join us today. Dr.
Okay.
Rosenkranz is Assistant Professor of Surgery at Dartmouth-Hitchcock Medical Center, and she is a surgical oncologist and currently directs the Comprehensive Breast Program at Dartmouth. Dr. Rosenkranz has recently co-led a team at Dartmouth to do an exhaustive literature review on the evidence around screening mammography. So I've asked her to join us and comment on the appropriate use of screening mammography in the perioperative period for women undergoing breast reduction. So welcome, Carrie.
Thank you very much.
So tell me, what would your advice be to the woman who is contemplating breast reduction and wondering whether she needs to get a mammogram before her surgery or not?
It's an area of national controversy in terms of what age people should start screening and how frequently. Without delving into that controversy, what I would say is for any woman over the age of 40 who's contemplating or planning breast reduction, I would recommend getting a screening mammogram sometime within 6 months of the planned breast reduction.
Is there anything unique or circumstances that might change that opinion in terms of your recommendations?
That's an excellent question, and I think the one group who might want to consider doing so earlier, before the age of 40, would be in the high-risk patient population, particularly women with a very strong family history of either breast or ovarian cancer, particularly early breast cancers. Women who have either gone through genetic testing or have risk factors for carrying a genetic mutation but have not been tested probably should start with their screening mammograms in general earlier than the age of 40. But certainly in the setting of breast reduction, where you don't want to miss an occult breast cancer, should have a mammogram also 6 months prior to planned breast reduction.
So the fact that we're doing breast reduction surgery, does that change anything about the screening recommendations, or we just apply the same screening recommendations and take the breast reduction surgery as an opportunity to make sure that we're providing good care?
I think the place where it may change recommendations is for women who may contemplate not screening, particularly in the 40 to 50 range, where I think most of the controversy lies. It depends how you interpret the guidelines. But based on our analysis of the literature, where I think there are many women in the group between 40 and 50 who maybe don't need to screen, I would still recommend prior to reduction doing so, mostly to avoid any mastectomies for very early breast cancers, which would have been preventable with a pre-breast reduction diagnosis.
Implying that if we'd found the diagnosis in the reduction specimen, their only option then would be mastectomy?
Correct.
Yeah.
Typically speaking, yes, because of the difficulty with margin assessment.
So in our analysis of the current practice patterns of surgeons participating in our board's maintenance of certification program, there is somewhere between 10 and 15% of surgeons who are advocating mammograms on all their preoperative patients, really apparently regardless of age. So what would your advice be to them that would convince them that practice perhaps should be changed?
Really before the age of 35, most women have such density in their breasts that the sensitivity would be 80% or less in that setting. So I'm not sure that we're picking up these small cancers, which you'd be trying to pick up in women who are older or with fattier breasts to start. And the risk-benefit ratio, particularly in the population before the age of 40, without risk factors, is really just so low. The incidence of breast cancer in that group is so low that I think to be getting screening mammograms on an 18 or 28-year-old just doesn't make sense in terms of utilization of medical resources.
Other than the cost, is there a downside to it? Are we likely to do harm from the radiation or overdiagnosis?
I think to answer your first question, in terms of irradiation, although a lot of patients are concerned about the risk of radiation from mammography, it's actually an incredibly low dose radiation. And I think, truthfully, that's not a risk factor to these women. But the false positive rate and the stress related to that, as well as the cost of potentially unnecessary biopsies, a lot of these women are going to have stressful callbacks. Many of them will have biopsies. And I think the yield, again, with the incidence being so low in that population, really doesn't warrant the study.
Great. Well, thank you so much for joining us, and I think our readers will really appreciate your comments and help guide us in providing the best evidence care possible to our patients. Thank you.
Thank you.